In 1999, we turned round and went in a completely different direction. We got rid of Mrs. Thatcher's trusts, which were setting one hospital against the other, and went back to being a single Scottish unified health service. And that has allowed us to do all sorts of work on patient safety and setting quality standards for diseases. But we don't control everything, and we don't control welfare, which obviously has a major part to play in poverty. We don't control the wealth we generate. It all goes down to London, and then we get our pocket money back. And while yes, we have powers, we don't control the size of that purse. And therefore you're sitting there, if you're giving more to one thing, you're taking it away from something else. And to me, I think we should be standing up and taking responsibility, work hard, earn our keep, and then have control over how you spread that out.
There are fears at the moment, it's just the big controversy is about how the NHS in the rest of the UK is being handled, well, particularly England, about outsourcing, privatisation of services. But there is private money, private company money going into the NHS in Scotland. I mean, how do you define the difference between the two countries?
Well, I mean, what has been referred to in the last week or so is talking about waiting list initiatives and things being done in private hospitals. What I would say is, if you went back to before we had devolution, when I was a trainee, there was enormous amounts of that being done, trying to get people off waiting lists. There are a few health boards who currently have a problem and are using that, but the vast majority actually do it in-house. So you get asked to, can you do a clinic in the evening?
That's what I mean. Is that what you, when we say there's private money being used in the NHS?
It's mopping up waiting lists. Yeah. It's not handing chunks of our core NHS over to Virgin.
Is that the difference then?
That is the difference. And you know, what has been laid down by Labour was bringing in private companies to set up independent treatment centres in England, and then to change the rules to any qualified provider. And therefore, they laid the foundation that the coalition changes are built on. What the coalition have done is obviously break things up into these GP commissioning groups, but they have one rule: all services must be put out to tender. And clearly Virgin is a huge company. They have bid teams, they work out how to come in and win that bid. If they have a private hospital up their sleeves, they may take, say, knee replacement patients and go and do them somewhere else. Well, your local NHS knee replacement department is now not getting any funding, so it will disappear. What they often have is that they don't have a hospital up their sleeve. So they say, well, we'll take that off your hands, we'll use your equipment, we'll use your staff. Staff and equipment we bought, trained, invested in, that's then handed over to them. And so in 5 years, when that franchise is up, Atos might come in and kick them off. But the NHS hip and knee department in that area doesn't exist anymore. So it can't bid to take that back. I mean, this is a one-way direction of travel. And the problem is they cherry pick the easy stuff, they cherry pick the fit patients, and therefore the NHS is getting left with the complex, expensive patient, the complex cancer, the diabetic, the stroke, the person in intensive care. They're not interested in these people. And that's why they're all in debt.
Is it fair to say is a threat to what we currently know as the NHS? I mean, if you speak to many people on the street, as it were, and said, does it bother you, who provides the service? I mean, they tend to say, well, no, not really, so long as I do get the hip or whatever I need done. I'm not sure that so many of the public, we talk about retaining the NHS, I'm not sure that people see that as a threat to the NHS, is it?
Well, I think that down in England people are beginning to see that. If you look at the English media and the Labour Party south of the border, people are up and out talking about it being balanced on a knife edge.
Well, there's a march, isn't there? There's a kind of second Jarrow march on its way to London about the NHS.
There's a group called the People's NHS, which is trying to protest against these, trying to protest against the free trade agreement and the danger that has of bringing big US companies into it.
That's at a European level, though, isn't it? That's a kind of American Europe.
Exactly. But there is also the, oddly enough, called NHS Together, which is actually a group down south of staff protesting at privatisation in the NHS. So down there people do see it as a real threat. And when the GPs commission services, obviously they decide what they're going to provide in their area and what they're not. And so you are beginning to hear anecdotes of people having to pay for something they didn't used to pay for. It's stuff out on the edges, it'll be stuff where maybe the numbers of patients are small, but it is that drive. And because of the debt, I mean, there's more than £500 million worth of debt at the end of just 1 year. Suddenly, there's much more talk of charges. Now, not politicians, but Reform UK and the King's Fund, it's more in the papers. The Health Minister in Northern Ireland talking about, let's charge drunks who come to accident and emergency. So are you going to breathalyse them? How will you define them? What about someone barbecuing, having a beer, gets hit with a cricket ball? Will that count? That's self-inflicted, so what about rugby players and hang gliders? You know, it's the, oh yeah, we would all agree, drunks, they're terrible, they should pay. And then it just begins to move. And people are phoning in to radio programmes and saying, well, I would pay £25 to save the NHS. I would pay £10. But I'm sorry, if you're paying £10 or £25 to go to a GP or accident and emergency, you haven't saved the NHS. That's the NHS dead. The 66-year experiment of free care at the point of delivery is over.
In terms of our debate in Scotland, though, the yes side maybe needs to be a bit careful here. There's a kind of suggestion that if you outsource in England, because of Barnett consequentials, that less funding will make its way to Scotland to pay for health services. Now, that's not actually true, is it? That's not how it will work. The money will, if the money's paid out as we currently understand the Barnett formula, if there's going to be a Barnett formula after a no vote, if that's what happens. But it's not true that the money wouldn't follow as things stand today.
Well, obviously, if you saw the Scotsman or Herald this morning, you will see that the Barnett is right up there in the headlines of that it really has a big target painted on its back, and that would take a lot of money out of our budget. But yes, I mean, at the moment, because the first year of changes have failed, you know, stupendously, and they've actually had to pay more, we have got more. But, you know, they didn't sit down and say, let's franchise and privatise the NHS so it costs us more. The aim was to save at least £1 billion a year. Now, the fact that they've failed can't really be put as a virtue. That is their long-term aim. And to my mind, the problem in the long term is that this direction of travel has been running since the late 80s, when Mrs. Thatcher talked about we should move to an insurance-based system like America. NHS couldn't do it, so she set up the internal market. Instead of Labour getting rid of it, as they said they would, they moved to big foundation trusts who got even more financial freedom. They set up the independent treatment centres, they changed the rules. Coalition, now we have an open external bidding market. The direction of travel is clear, and it's been going on for 30 years. And I don't think that's what we want. And if they do end up in a more insurance-based system, so if people were paying charges, well-off people would just say, well, I'm not going to bother with that, I'll just take a bit more private cover, or I'll take Virgin Plus, then you will start to see that go down.
But I mean, is your model of the NHS, I think some people might be vaguely disturbed at the idea that, you know, it is, I think, still the biggest employer in Europe, the NHS, that it, almost on a kind of Soviet scale, you know, that there's one boss who dictates what you'll get right down through the system. And I mean, there are inefficiencies in huge organisations unless you have clever managers at the right level, and setting some type of internal target to say we need to hit these. Otherwise, you know, it becomes inefficient. I mean,
sure,
you know,
but I mean, what's happening down south is that those managers are now focused on the survival of their hospital. So their entire aim is winning a contract, getting patients through the door. They get payment by results per patient.
They're more like accountants, really.
Yes, so that is the drive, and that was blamed a lot for the Staffordshire scandal, that trust was trying to get foundation status, and that's all they were thinking about. So that is their drive. But if you look at the Commonwealth report, Mirror Mirror, which was published back in May or June for 2014, now that is a Washington-based think tank, it's nothing to do with the Games, and they compare the US every few years with other health services. And based on 11 to 13 data, the UK came out number 1. They measured 11 parameters and we came top in 8. Quality, safety, efficiency, patient access, patient-centred care. We came third in waiting times. We came 10th in life expectancy, which, as they said, is much more to do with poverty and deprivation. A health service can't change that. But you would then think, well, were we so expensive? No, we were second cheapest. The only one cheaper than the UK system of just tax in and healthcare out was New Zealand, where you do actually have to pay. So this idea that we are this, it can't go on, the NHS is appallingly inefficient, is simply not true. And that was comparing with Germany, with France, with Australia, Canada, America. So if we are so efficient and if we are so cheap, why have they thrown a grenade into NHS England? In my mind, it's ideology, and that is back to this principle that they simply believe that the state shouldn't run stuff. It should be moved into private hands and the market should run it.
I don't think Labour are saying that, though, aren't they? And that's not the Labour message. They're trying to say to us, no, you vote no in this referendum to retain the union because that's where the broad shoulders, deep pockets are, and they explicitly say that's how you save the NHS, even though it is already separate in Scotland.
Well, it is already separate in Scotland and was always separate, right? From 48, we had our own kind of NHS Act, if you like. But it still comes back to the fact that Scotland sends more money to Westminster than it gets back. So in actual fact, if we were simply living from our own means, from the work of our hands, if you like, we would have had more than 8 billion more to spend in the 5 years from the crash than we've had. So we could invest that. I mean, that's 1.5 billion, more than 1.5 billion a year. That could have put an extra 10% into the NHS, an extra 10% into schools. So, this idea of the broad shoulders of the UK isn't actually true. We lose more money than we get back. And, there's quotes from Unite in 2009 challenging Andy Burnham and Labour because of the privatisation that they were doing at the time. So, the idea, vote no, and then Ed Miliband will come galloping over the hill in just one Christmas and save the NHS, I think is not really true.
There is a kind of conceptual idea that worries some Scots, though, and that is that if you do it yourself and become independent, run your own health service, that you kind of cut off. You do make a frontier there between Scotland and England. You have to run it yourself. You're no longer sharing. And a lot of stuff that goes on just now, we do share across the UK. Services and transplants is one of the ones that's been mentioned. I mean, do you think there's any possibility of that idea where we would no longer work on blood services, for example, between Scotland and England?
Well, no, not at all. I mean, when Gordon Brown came out and said that we wouldn't get organs or blood transfusion if we voted yes, the NHS Blood and Transplant, which only provides blood to England and Wales, had already written to Nanette Milne last August to say this isn't true. Organs are already both harvested and given right across the British Isles, including the Republic of Ireland. And they felt this would not change at all. So that was their view. And Scotland has the Scottish National Blood Transfusion Service. So I'm sorry, we've been donating and providing our own blood for years. For patients who have very rare blood types, they all cooperate with each other. So if we couldn't source it, they would see if they had a donor and vice versa, and that wouldn't change. And our very specialist services like Great Ormond Street, which Vote No Borders put up in the cinema, it was the hospital that made them take it down. Because as they said, they treat patients from 90 countries. And we already pay every penny of that. Your health board pay for anything that is done south of the border. Occasionally I have to send patients to Leeds for quite a specialised type of biopsy. I have to get permission from management and we have to pay the money. So we don't get given that, we pay for that through service level agreements. And those things are actually protected by EU directive and therefore would not change. And a lot of them are across multiple countries and happen in Europe as well.
Okay. Just lastly, how are we doing on breast cancer in Scotland?
Well, we've been improving steadily. Survival has improved. I mean, I went into breast cancer when I was quite a wee girly surgeon at a very early stage. And the transformation in how we treat patients, how we support them, and the outcomes we get is unrecognisable.
Is that before the surgery level? I mean, are we better at that side, or is survival after surgery improved?
It's better at all levels. I mean, I decided I wanted to be a breast surgeon quite young and used to get laughed at that they didn't exist. And after breast screening was set up, literally the whole service developed. So it's been recognised and looked at in research, and it isn't just one key thing that has made the difference. It's trying to get every piece right. And that's something we do in Scotland. We have quality standards. We meet every year. We look at everyone's data against these, not waiting times or numbers, but actual, how did you do on the quality standards that will make a difference to that patient? And we criticise each other, but we also share ideas and solutions. And having led on that back in 2000 in writing the standards, what you can see is the quality of that care just move up and up year after year for 15 years.
You sound quite proud of that then.
Oh, I am proud of that. I think that was one of the big benefits we got from going back to working together as a single NHS in Scotland. And I think that it has led us in a totally different, more quality-based direction.